There was no respiratory distress, jerks absent, tongue fasciculation was present, and bilateral undescended test. On shaking hands with mother, she couldn't leave the hands, probably indicating myotonia. We'll come back to this case after this discussion is over. There was no respiratory distress, jerks absent, tongue fasciculation was present. Floppy infant is the one who presents with hypotonia at birth or at early infancy. So what is hypotonia? It is reduced resistance to passive range of movements in joints or an impairment of the ability to sustain postural control and movement against gravity. Hence, an hypotonic infant can be defined as the one with poor control of movements, delayed motor skills, and hypotonia. Dysfunction at any level in the nervous system can cause hypotonia. Central causes, both acute and chronic, are anyway more common than peripheral ones. So what are the important points we need to take back with history? Amongst antenatal history, there could be decreased fetal movements in utero, fetal presentation, mostly breech presentation is mostly associated with hypotonia, amount of amniotic fluid present. Maternal exposure to toxins generally indicate a central cause of hypotonia. Low Apgar scores suggest floppiness from birth. A term healthy infant developing floppiness after 12 to 24 hours is suggestive of inborn errors of metabolism. So there could be two causes. Antenatally, there could be central injury at birth. In that case, it develops increased tone and DTR, exaggerated deep tendon reflexes, while central congenital hypotonia does not worsen with time, rather it becomes more apparent with time. The features which are suggestive of central hypotonia, there could be depressed level of consciousness, predominantly exer weakness, normal strength with hypotonia, reflexes could be hyperactive or normal reflexes. Other features include dysmorphic faces, twisting of hands, seizuring on vertical suspension, and features of cortical dysfunction is generally like early seizures, abnormal eye movements, and irregular pattern of features which are suggestive of peripheral hypotonia. The child will be alert, responding to sound appropriately, surroundings appropriately. There will be normal sleep-wake patterns. Profound weakness alongside hypotonia and hyporeflexia. Muscle atrophy, lack of abnormalities of other organs, and fasciculation of tongue as a form of intention tremor, which is classical of spinal muscular atrophy. So overall, the clinical pointers could be inspection on something amongst inspection, assessment of head size, shape, posture, and movement. Amongst posture, important is a floppy infant lies with limbs abducted and extended. Tone assessment could be by horizontal suspension. Generally, the child will be in a characteristic inverted U posture. Vertical suspension, the child tends to slip through the shoulder girdle and head lag on traction. Other features which include poor trunk extension, aesthesia, decreased resistance to passive movements. Pointers which are specific to central hypotonia include social and cognitive impairment in addition to motor delay. Syndromic features like dysmorphic organs or other organ involvement, twisting of hands, reflex would be normal or bridge, features of pseudopulvar palsy, wrist, Georgia, and upper motor neuron signs, history of hypoxic ischemic encephalopathy, birth trauma, deep tendon reflexes would be exaggerated, clonus could be present. Pointers which are specific to peripheral hypotonia, there could be relatively normal social development, family history of neuromuscular disorders could be present. The reflexes will be particularly reduced or absent. A particular posture which is specific to peripheral hypotonia is frog-leg posture or jug-handle posture of arms. Muscle fasciculation, muscle atrophy or hypertrophy could be present. So the first picture depicts the particular U-shaped posture on horizontal suspension. The next two pictures are generally suggestive of the hypermobility and laxity of the joint. The last image is basically W-shaped sticking, which is indicative of the laxity of joints at knee and hip. Again, the first picture is the vertical suspension test. The second picture is lid lag on traction, and this is the characteristic frog-shaped posture. So diagnostic clues and examination. Generally, abnormalities of respiration could point towards congenital myopathies. Cardiomyopathy could be seen in carnitine deficiency or Pompe's disease. Hepatosplenomegaly is generally seen in storage disease. Abnormal urine color could be depictive of ocular venocerebral disease. And hyperpigmentation undescended testis is seen in Prader-Willi syndrome. Conditions, so that differential diagnosis of central hypotonia could be broadly classified into acute encephalopathies, chronic, and the connective tissue disorders. So acute encephalopathies include birth trauma, HI, and hypoglycemia. Chronic encephalopathies could be cerebral malformations, palsy, chromosomal disorders, paroxysmal disorders, connective tissue disorders like Ehlers-Danlos syndrome, congenital ligamentous laxity. Coming to peripheral hypotonia, spinomuscular atrophy, paralytic poliomyelitis, neuropathies like acute demyelinating polyneuropathy, neuromuscular junction problems, myasthenia gravis, muscular disorders like congenital myopathies and muscular dystrophies. Here's another categorization of the hypotonia. Could be broadly classified into anterior horn cell disorders, metabolic and multisystem disorders, congenital myopathies, congenital motor or sensory neuropathies, muscular dystrophies, and neuromuscular junction disorders. A few pointers to our specific disorders. Trisomy 21, the Down syndrome, commonly is the most common abnormality causing this developmental disability. It is associated with intellectual disability as well as congenital heart defect. Fragile X syndrome associated with macrocephaly, macroorchidism, CGG repeat in FMR1 gene. Prader-Willi syndrome associated with intellectual disability, obesity, short stature, and chromosome 15 abnormality. Myotonic dystrophy, the symptoms usually begin in young adult life with weakness of facial and distal limb muscles, cataracts, and myotonia. Congenital myotonic dystrophy, the infants are born to affected mothers. There could be history of polyhydramnios, prolonged or assisted delivery, can require ventilation. Spinal muscular atrophies, degeneration of the anterior horn cell and spinal cord, motor nuclei of the brainstem can present from birth to adult life. There is marked generalized distribution of weakness. There is myasthenic syndrome, which is generally a persistent episode of weakness with apnea, ptosis, and oculomotor paralysis. Could be autosomal recessive in inheritance. And transient myasthenic syndrome is a passive transfer of placental antibodies. There is difficulty in feeding. It usually begins from hours to 3 days of birth, and recovery is within an average of 18 days. So the investigations, if you are suspecting central hypotonia, are serum electrolytes like calcium, phosphorus, ALP, VBG. Brain imaging could be done, chromosomal analysis, medical genetics, plasma amino acids and urine organic acids, mucopolysaccharide screening, and we can take an ophthalmologic opinion. For case of peripheral hypotonia, we could do a creatinine kinase, lactate, myographic studies, nerve conduction studies, repetitive nerve stimulation, muscle biopsy, genetic testing, and nerve biopsy. Management is generally supportive in these cases if in case we cannot manage the specific cause. So few cases of specific treatment like hypothyroidism could be treated with thyroxine. Some forms of congenital myasthenic syndromes could be treated with pyridostigmine or neostigmine. Rickets could be treated with vitamin D, and some other metabolic errors which could respond to dietary modification. Physiotherapy, occupational therapy, symptomatic treatment like respiratory support, management of gastroesophageal reflux disease, NG tube feeding, gastrostomy, and caloric supplementation. Here's a table showing localization of disorders. Important takeaway point is the tone is decreased in at all levels. Central injury will have specific increase to normal deep tendon reflexes. Babinski sign could be positive to negative. Central developmental delay is same. Anterior horn cell problem will particularly present with muscle fasciculations. Peripheral nerve issues will have muscle mass which has distal atrophy and deep tendon reflexes will be decreased. For neuromuscular junction, deep tendon reflexes could be normal to increased. Muscle fasciculation is absent in this case. And if it is a muscular disorder, there will be a proximal muscle atrophy and deep tendon reflexes will be definitely decreased. Again, the same table of differentiating the sites of music. Sir, videos gulo ওই ল্যাপটপটা দেখতে
like a rag. After condition, if you don't know how benign it is, but there is some entity still benign and we see that they improve the age. Whether it's a metabolic problem, genetic problem, and it actually it starts from right? The teaching by the mother. Our kids have to then you start thinking that they might have a teacher and he has given a clue that breech delivery. If you are having a breech delivery, then it is that we didn't have the commercial. Whether the rate of operation so the breech delivery is a clue. And then prolonged second stage of labor is again that we get pressure. prior to the whiteout, there are a lot of other causes. Steroid sulfatase deficiency. Steroid sulfatase deficiency. They will have wrong second stage of
contraction.
Second stage of labor. Second stage of liver relax with the banana. Like 0, 1, 2, 3, 0 doesn't feature total apoptosis of the hormone cells. And then type 1, they are usually presented as one. And then there are some speakers and there are some non-workers. And then and then there is another one which is called Redis will be endocrine. Ready হচ্ছে very weak endocrine Corona hobby, back for the doctors to get this yesterday. Next,